Hi, well, it's July 2017 and I'm just back from SMAC in Berlin. Had a wonderful time. And I was asked to put together some cases for the pre-conference workshop. These are my cases. Now you might ask what on earth a small hospital on trauma bypass has to say about eFASTs and ectopics. eFAST is very important for us. Now, we see around 150 to 180 presentations per day. This is mixed adults and kids. Major trauma goes down the road to the tertiary hospitals. But in spite of this, our registrars will find about one ruptured ectopic, usually on night shift, each month. And I think this alone justifies learning the eFAST protocol, in spite of the fact we're on trauma bypass. The other thing I have to say about the eFAST protocol is that it's great training wheels. When you learn to put your probe in the right upper quadrant and identify Morrison's pouch, you're actually finding a window not just to Morrison's pouch, but it's a window to the right kidney. It's a window to the gallbladder and a look at the liver as well. Really what we're doing is finding good viewing spots for the abdomen, and you expand on this with all the other scans that you do. So please do take time to learn to do a good eFAST scan. It'll hold you in good stead ever after. Now case 1 is a young man from a motor vehicle accident. He actually walked in, that's how come he got to us. He complained of right-sided chest pain and dyspnea. We thought we'd have a practice, so we did our fast scan. The right upper quadrant was clear, the left upper quadrant was clear. That, in fact, is his stomach there behind the spleen. Don't get confused. His bladder was fairly normal suprapubically, and the subcostal heart was also good. Now his chest, remember I said he walked in. He managed to get an erect chest x-ray before we got to him. And looking at this chest x-ray, would you like to hazard a guess as his pathology? Remember, it was right-sided pain and dyspnea. Anyway, we put the ultrasound probe on as well. As is obvious, there is a pneumothorax anteriorly. You can see the barcode on the left, M mode, and if you look closely with the straight probe, you can see that that pleural line is not moving sideways at all. Sure, it's moving with respiration, up and down, but not sideways. There's no sliding. This is a worry for a pneumothorax. Moving laterally in the anterior axillary line, the picture on the left shows you what's called a lung point. This is where a little bit of normal lung on the left is sliding in and out of the air on the right. A lung point is very specific, 100% specific for a pneumothorax. Moving further into the axilla, we can see the picture on the right. This is B-lines. It's what you look for in heart failure. But in a fit young man who's just had a car accident, it's far more likely to be a lung contusion. So, scanning posterobasally, we find that those B-lines become brighter and confluent. This means he's probably got quite a significant posterolateral lung contusion. This view here shows just a little bit of the diaphragm and the liver, and there is no spine sign. In other words, there's no fluid behind the diaphragm. We can rest assured that we don't have a hemothorax here. So what does this lead you to expect for the CT? Yeah, here it is. We saw that small anterior pneumothorax, and we saw that lung contusion, and we didn't see any free fluid in the pleural cavity. The trap for new players, though, is that when you see a pneumothorax, you can find the extent on the surface area, but you can't tell how deep it is. There's no way you can tell if it's 2 mm sliver of air or a 2 cm pocket. The learning point, though, from this case is that you can trust your lung scan over supine chest x-ray, and sometimes it is as good as erect chest x-ray. If you have time, it's very useful to try and plot the surface area of a pneumothorax because it gives you an idea of the size. Case number 2 is a young man with tachycardia and tachypnea. Not trauma, but unfortunately a recent diagnosis of metastatic cancer. Now, cancer patients are at increased risk of pleural effusions, pericardial effusions, even with tamponade, ascites, sometimes with bacterial peritonitis. They can bleed, they can clot, and they can have gut obstructions. So really, these patients can have a huge benefit from POCUS. And in this young man, we have to ask, what's the differential tachypnea and tachycardia? Now, first of all, I checked the lungs. They were fairly non-specifically dry. There were no obvious consolidations or infarcts or fluid. I looked at the heart. Now, he was a large fellow, so we had to get a very narrowed down view. This is the parasternal long axis view. And from it we can say there's no pericardial fluid, and the right ventricle's not too big, and the left ventricle appears to be working quite hard and fast. The little we can see is ejecting quite avidly. His liver, that's his liver on the left, looked terrible. And on the right we have a longitudinal suprapubic view. This is a weird look too. There's actually quite a bit of free fluid with some bowel floating in it on the left, but on the right we have a non-specific homogeneous middle grey thing stuff. What we're actually seeing here is particulate matter in the free fluid, most probably a clot. So in summary, we have grossly clear lungs. They're not causing this young man's symptoms. We have a heart that's responding to the insult. It's not the cause of the problem. The liver is grossly abnormal, and there is ascites. However, there appears to be a particulate suspension that's clumped together. This is very suspicious for hemorrhage. The next step, obviously, in this case was an aspiration, which proved hemorrhage rather than peritonitis, and expedited treatment considerably. Now, there are other examples of non-black free fluid. On the left we have a suprapubic view again. That's a big bladder at the front. Then we have a uterus in the middle field, and behind it we have a middle grey stripe which, if we'd turned the gain down, would have shown to be black. Behind any fluid-filled structure you have increased brightness. We call it post-cystic enhancement because the sound waves have had a lovely time going through the fluid and they're not in the least bit tired. It's a very good idea to turn the posterior gain or the TGC down in these patients. Now the picture on the right again has a transverse across the pelvis, and the bright structure in the middle is the uterus, and the mid-grey above and below is clot. In fact, there's only a tiny bit of dark black fluid at the back of this clot. This means we've got quite extensive hemorrhage here, but it might be misleading if you were only going by the black. Now both of these pictures would have improved by turning down the gain. Now once you've found your free fluid though, we then tell you to turn the gain up. We're not being schizophrenic here. Turn the gain up after you've located the free fluid, because as you can see, sometimes you'll pick up tiny swirling particulate matter, sometimes called the plankton sign. This is a pleural effusion here, and that V shape is collapsed lung, and what you're looking at is an exudate swirling around in the pleural fluid. Now the converse of this rule is also a problem, in that not all black fluid is free. Black fluid may be in the wrong place, but it may be contained. On the left we have a collection in the right paracolic gutter. You can guess that it's contained because it's round and it's not really obeying gravity. So it's held in this particular place. On the picture on the right we have the lower pole of a kidney, and the fluid you're seeing here is actually limited by the peritoneum. This is retroperitoneal fluid, in this case from a ruptured ureter. So again, it's not obeying gravity, it's obeying the confines of the retroperitoneal space. It's important, it's fluid where it's not meant to be, but it has different connotations to your free fluid in a fast scan. Going back to it, we also have a anterior fat pad on the subcostal view of the heart. You know this is unlikely to be fluid, most likely to be fat because there are some grey speckles in it, and more importantly, it doesn't continue posteriorly round the back of the heart. Now in this picture, the back of the heart is the most dependent portion, so if this was truly free fluid, we'd be expecting it to track down behind the left ventricle. So the learning point from this case, not all free fluid is black, and not all black fluid is free. What you have to do is watch how it moves. If it sinks to dependent portions and moves independently, then it's free fluid. Case 3 is a 60-year-old with dyspnea. The patient had had 12 hours of tiredness and epigastric discomfort. Previously well with no trauma, a smoker in a high-stress managerial job, and now comes in tachycardic and tachypneic, just not feeling well. The ECG, bloods and OBS were unremarkable except for the heart rate of 120 beats per minute, which was a sinus tachycardia. No troponin leak either. Now, this was 3 a.m. When I walked past this patient, noting the slightly blue colour and the anxious expression, my first thought was this has got to be a PE. Because it was 3 a.m. in the morning, that thought of PE just fixed itself in my head. So I put the probe on, fully expecting to show a big right ventricle. This is a rather odd view of the parasternal long axis, but it's really only odd because the patient has a somewhat sigmoid septum. Unfortunately, that RV is not big. The heart really appears to be trying hard and ejecting as much of its volume as it possibly can. But this wasn't enough to dislodge that fixed idea from my head. I thought, no, the patient's blue, she's got to have a breathing problem. I looked at the lungs and there was sliding on both sides, but not in the still pictures obviously. No B-lines and no obvious consolidation or fluid. This still didn't deter me from my diagnosis. I did try and find the IVC, but I couldn't, so I had a look at the right ventricle from a different angle. This is the parasternal short axis view, and the right ventricle is that crescent that's curving over the aortic root in the middle. But still, it's not big. You'd think I'd be starting to get the idea by now, but no. I did go looking again for the IVC, but instead I found the aorta. It looked okay. You can see where the IVC would be entering the right atrium here, but I couldn't actually extend it out. So I thought I'd go to the right upper quadrant and see if I could see the IVC from the side, and I got a bit of a fright. This was the first thing that jerked me out of my fixation on PE, and that's free fluid in the right upper quadrant. I hastily looked across to the left upper quadrant and shook my head. It looked a bit weird. Looked around a bit more at the spleen, and I couldn't make it look normal no matter how I held the probe. Looked down in the suprapubic view, and at first glance this looks like a bladder, but if you look more closely you realize the bladder is actually that collapsed thing down there, and this is actually free fluid sitting above the bladder. So summary, we have a heart that's beating hard. Lung bases on the fast scan looked fairly clear. There was free fluid in the abdomen. The aorta was okay on the view we obtained, but the spleen looked very suspicious. Now, at 3 a.m. means we have to call our CT personnel in from home. This is a big call in a small hospital. But sure enough, we found a spontaneous rupture of the spleen with ongoing bleeding. eFAST is useful for more than just trauma. Case 4 is a young girl with lower abdominal pain, no period for 8 weeks rather. Now in these patients I usually start on the right and left upper quadrant. because if there's fluid already tracked up to here, then you know you've got significant condition, significant hemorrhage. And I start the up triaging process immediately. Start tracking down drips, cannulas, bloods, and extra staff. Looking in the pelvis, starting deep and steep in transverse. The first picture on the left looks okay, but on the right, as we pan up through the uterus, we can see that there's fluid behind the uterus and perhaps a little bit in front as well. In longitudinal, we can still see fluid behind the uterus and, concerningly, no obvious gestational sac on the left. On the right, it's just a grey mudgy mess, but it's a deep grey mudgy mess. I'm always worried when I can see 15 centimetres down into pelvis, because normally you can't. Normally there's bowel gas in the road and rectum. Something has displaced it. This is a worry. Now nothing on earth. This one on the right is actually collapsed, ruptured ectopic. You possibly wouldn't recognise it if it wasn't the tender spot. Now, sometimes you do see some sort of sac in the uterus, but you can't stop there. You have to decide, is this a sac or a pseudo-sac? Now, to call it a gestational sac, it must have either a yolk sac within it or a fetal pole, preferably with a heartbeat. Now, the yolk sac tends to be a very distinct, gives a diamond ring shape. It can be quite hard to tell the difference between a sac and a pseudo-sac, and I've always found this diagram from the AIU the best. A gestational sac generally implants eccentrically, and the endometrial stripe usually diverges around the edge, deviates around the edge. Conversely, a bleed within the endometrial cavity is usually central, and the endometrial stripe splits around it. So an implantation sac looks like this picture here on the right, whereas a pseudo-sac looks like this picture here on the left. Now be very careful how you report this, because we have run into trouble with people blithely calling it a sac in the uterus but no fetal pole or yolk sac, and this has still been misconstrued as a gestational sac. Now be careful, just occasionally these very retroflexed uterus will look like clot in the posterior fossa. And likewise you can get some very complex and interesting cysts. This picture on the right was actually beside the ruptured ectopic we saw in the previous picture. And whatever you do, always ask about ovarian stimulation therapy. Thank you. I hope these cases have been useful. Bye-bye.